I'm wondering if on a night when there's a talk about organ donation, whether Oregonians see a few snowflakes and worry that they might have to become an organ donor if they drive here. In any case, I'm very grateful for those of us who are here. I'm very grateful to our two presenters, friends, co-teacher, and I'm just going to turn the floor over, and I'm going to invite everyone to come on up. This is a intimate group, so let's just pretend we're all friends, and Ingrid and Jennifer will take over. So come on up.
We're live streaming, so
yes.
Excuse the very loud.
Very loud.
It's gonna be very.
And then you can wander around.
I'll give it a try.
A little closer.
Like that.
Actually, like this.
How's this?
Better.
That's probably better. All right. Otherwise, I'll be licking this later. So, my name is Ingrid Siegman, and I am a clinical nurse specialist at the Portland VA. So, for those of you who don't know what a clinical nurse specialist is, it's you probably have heard of a nurse practitioner. So it's the same category. The difference between a clinical nurse specialist and a nurse practitioner is that I'm trained to specialize in something, which is transplant, as well as to work on systems issue, which is transplant. So I wanted to start with some general information. So this is information that I found on the 25th of February. So this is updated on a regular basis. And that information kind of speaks for itself. But what it's really communicating is the demand. And here's another picture of what that organ demand looks like. The yellow bar that you see at the bottom, that's the donors. The blue bar that you see, that's the number of organs we're able to get from that set number of donors. Because as you know, we can get multiple organs from each donor, potentially. It depends on their health. It depends on what their cause of death was. So, but that's what we've done over the last couple of years. You see those lines are going up. That's good news. That means Amy, who is in the back, who's joined us from Donate Life Northwest, is doing a really good job of getting the word out there and getting people to donate. So now, the pink line, that's the demand for organs. These are all organs. As you can see, that has gone up too, but at a much different rate. So why has it gone up? Well, we're better at what we do, so that's one thing. Our population has gotten older, and so we're seeing more things like kidney failure. We have more obesity in the United States, which can lead to kidney failure. We have, it also leads to diabetes, which leads to kidney failure. So a lot of this is driven by kidney disease. So that is the organ that's in the highest demand. Good news, everybody's got two. So the other interesting thing here is that despite the fact that people are willing to donate, the reality of the situation is very few people actually meet criteria when the time comes to donate an organ. If you lived a long, healthy life and you die in old age, your organs are also aged well. The other thing is that even though people report that they're supportive of organ donation, they don't always mention it to their families or have that information recorded. And as you probably know, the DMV is a great place for making those wishes known. So a little bit of history about transplant. This was a first successful transplant. What do you notice about those brothers? Yeah, exactly. So in 1954, if you wanted to have a successful kidney transplant, you had to bring your identical twin. Why is that? Because we didn't have the medication we needed to suppress your immune system, and we didn't have well, that's the reason. We didn't know how to control the immune system, so you had to have somebody who had an exact DNA match if you wanted to be successful. So not a lot of transplants were happening. Since that time, we've continued to have donations of other organs. Right now, there's a lot of talk, you've probably read about like hand transplants and face transplants. So I would say that this is still an emerging field. There's a couple of game changers I just wanted to go over with you briefly. In 1968, that's when we had the Uniform Anatomical Gift Act, so that's when the political part of transplant started. That's where government started to get involved with what was going on in the transplant community, which was pretty small. 1972, a game changer, End-Stage Renal Disease Act. This provided Medicare coverage for patients who needed renal dialysis and kidney transplant. So that means now there was financial ability to cover the cost of transplant. Incidentally, the number that they give, one of the reasons that Medicare is willing to pay for kidney transplant is because it costs the same as 3 years of dialysis. So after 3 years of dialysis, it's less expensive. Does that make sense? 1983, the FDA approved cyclosporin. This was our first anti-rejection medication. So the complexity with organ donation and transplantation is that our body is going to reject anything that does not have the same DNA that we have. So what we need to do is take the dimmer switch to your immune system. So you know that switch in the dining room to get your mood lighting? So we just kind of turn down the immune system, and that way it doesn't see that the organ is from a different DNA source, right? So it doesn't see the donor DNA. The problem with this is suppressing our immune system. Is we also have an increased risk of cancer and viruses and things like that, right? That's what our immune system's job is. So in the process of not letting it see your new organ, it also doesn't do the job that the immune system is supposed to do to fight cancer and infection. In 1984, this is when things got real. So the National Organ Transplant Act came to fruition. And this act gave government oversight to how we allocate kidney transplant. It created the network that we now call United Network of Organ Sharing. It also spelled out different rules for transplantation, and we'll go over some of those as we move forward. 1988, we got our first preservation. So that means how do you transfer an organ from the donor hospital to where the surgery is going to take place, right? So the donor is in Bend. We've got to get that liver up here to Portland. How do we do that? We have a preserve fluid that provides those organs with the nutrition it needs for that short period of time. And in 1988, we had additional legislation that helped us with determining what it means, what death is. And we'll talk about that. So one of the most important things that has come out of this legislation is what we call the final rule. And it has been revised many times over the years. And in 2000, these are the key factors that we need to consider as we move forward with transplant. So the rules, my rules as a transplant provider. We need to make decisions that are good medical judgment. We need to make sure we're using that organ wisely. That's a scarce resource, and we have to be thoughtful. We owe that to the donor family as well as everybody else on the list waiting for that organ. We need to preserve the ability for centers to decide whether to accept an organ. So some centers are willing to accept lower quality organs. And so those are all decisions that hospital centers can take. We have to avoid wasting our organs. We have to make good decisions. So for example, my center, the Portland VA, we get patients that come from a very wide geographic area. I can't accept a liver for somebody who is in Hawaii and is not going to make it here on time, right? That's wasting the organ. So we have to be mindful of that. We have to avoid futile transplants. So what does this mean? There is a point that it's too late. We can't put an organ in somebody that's not going to recover. And then one of the things we're going to talk about today is promoting patient access to transplantation as well as efficiency. So a couple of ethical issues that I wanted to just talk about. We've got ethical issues on both the recipient side as well as the donor side. I highlighted the ones in red that I'm going to talk about, but I did want to mention some of the others, and Rivi will be discussing some of these. So on the recipient side, allocation policies. How do we decide who's going to get the organ? We have to balance our bioethics principles of utility. So we don't have a lot of organs, so how are we going to utilize these? Justice, we have to be fair to everyone. We have to consider people's decisions and their autonomy to make decisions as to whether or not they want to accept organs or if they, how they live their life. So that means no judgment. Access to the wait list. So some of the things that can present problems in getting an organ is where is it that you live and where's your closest transplant center? As well as can you afford your medications afterwards? On the donor side, there are different philosophies in different countries about whether or not you opt in, meaning you can choose to be a donor, or you opt out, meaning a country that assumes you want to donate unless you tell them otherwise. So, and we'll talk about that, Rivi will talk about that more. Defining death, so that's a big question we're going to talk about today. What is brain death? What is cardiac death? The selling of organs, so this is against the law to sell your organ in the United States. And then transplant tourism, that means going to other countries and getting organs in other countries. That could look like going to India, to a rural village, and offering to trade a goat for a kidney. And then while you're in there, take some of the liver and then take off before you leave antibiotics or any post-op care. So those are all some of the ethical issues that we need to consider. So I'm going to talk a little bit about allocations, how we decide who gets the organs. There's a lot of things that goes into this. So that includes things like how sick is somebody? So for example, the liver, lung, heart, those organs go to the sickest person. On the kidney side, however, people don't die if they don't get a kidney. If people don't get a kidney, they stay on dialysis, right? So you don't have that life-threatening comparison. So that's part of it. Is this liver or heart going from this small woman going to do the job in this big man, or vice versa? So there's a lot of things that go into deciding which organ is right. Also, how do we decide who's going to be who is the sickest person? They all look sick to me. They're all in the ICU. The other issue that we're having right now, this is current events, is how do we define the area in which an organ can go? So we know a liver has a certain amount of time that can be spent traveling, and then it's no good to be used. That time is different from a heart, and that time is different from a kidney. Kidney, we've got day and a half. A heart, we have a couple of hours. So currently, we have it set up that we have donation service areas, or DSAs. So you can see here, Oregon is pink. We are our own donor area. That means that if there is an organ in Bend, it's going to come to us here in Portland first, right? Because they're within our donor service area. Versus the kidney that's from Texas. We're not going to get the Texas kidney. They're going to stay closer in the area. So the current issue that we have with this is somebody filed a lawsuit. Somebody said there's this, in November of 2017, this 21-year-old said, I live in New York, the supply and demand is off, my lung disease is rapid, I'm gonna die, I don't think it's fair that I live in an area that has such a high demand and not enough organs. So I'm probably gonna die, even though had I been in New Jersey or Oregon, I might have gotten an offer. Then the same thing happened in liver. Again, people in New York said, our wait time is so much higher. If I lived in Oregon, I would be waiting 5 years for a kidney, but since I live in New York, I have to wait 10 or 12 years. That's not fair. So what wound up happening is the lawsuit came forward, and referring back to that final rule, they said one of the rules is that allocation is not to be based on the candidate's place of residence and place of listing. Are we doing that with our current system? So that's the question. Is those service areas where somebody's waiting for 10 years versus someone who's waiting for 5 years, is that fair? So what happens when we decide that the system isn't fair? Well, first there was a lawsuit, and they went to the government and said, we don't think you're meeting your own requirement. And so then the government went to UNOS, who's a contractor of how we do organ allocation, and said to them, what do you think about this? And then UNOS says to them, we agree, this isn't a very fair system. So what are you going to do about it? Well, we're going to create groups of each organ. So a kidney group, there's a liver group, there's a lung group, there's a heart group, there's an intestine group, and the community itself comes up with different proposals. So here's an example of, this is happening right now in kidney. There are 5 proposals, those are the ones in red. And so then they do modeling. So there are 5 different proposals. What will that actually, how will that create change? So great job, New York, right? You were concerned you didn't have enough organs. With this new system that's going to be in place, you're going to go from 468 to 629. They did pretty good. There's still a finite number of organs. So here's Oregon. Look how that's going to affect us. We now have to think about our organs going to places like California, who has a wait time closer to the 10-year mark than the 5-year mark. Right? So we have a finite number of organs. I ask myself, what does fair mean? Is it fair that Oregon, that has a high percent of people who are willing to donate, Amy's done a really good job here. Are we the highest? We're at least one of the highest. We're in the top 5 of states that are willing to donate. Some areas don't have those numbers for a variety of reasons. People who don't trust the healthcare system, people who have cultural beliefs that don't support donation. So although we've been able to shift some organs around, the problem still remains. finite number. So the other ethical issue I wanted to mention is types of donors. So we have two major classifications. We've got the living donors, and we've got the deceased donors. Within the living donors, you can either donate to a relative, and that's most of the cases. Usually, if somebody needs an organ, it's somebody within the family or their community who steps up to do it. So oftentimes, we look at relatives first because the DNA is more likely to match, and then we have less problems with the immune system. That's the benefit. If that isn't an option, then you've got unrelated living donors. This is the best kind of organ to get. You're getting a kidney from somebody who's healthy, right? You're not getting somebody on literally their last day of life. So on the deceased donor category, two types as well. One is the donor that's considered brain dead. The second is the donor that is considered cardiac death, right? So one is they're brain dead, their body continues to function, but they're on life support. There's no neuroactivity. And the second one is they don't meet those criteria, but if we take off the machines, their heart's going to stop. So, obviously this is controversial. When they first came out with the idea of brain death, people were concerned about whether or not, well, how do you know if somebody is brain dead? So in 1980, it was defined. It was legally accepted that there could be somebody who would have irreversible circulatory and respiratory function. That's what we know. Our heart and our lungs stop, right? That's death. That's no question there. And then the other one, when all the functions of the entire brain, including the brain stem, have stopped. But machines can keep things circulating. So all these laws are created, but we also have to marry it with the science. So when the question is, how do we determine who's brain dead, then we turn to the American Academy of Neurology. And they said, you need to have 3 findings to diagnose brain death. It's got to include unresponsiveness, apnea, and the absence of brainstem reflexes. So how is that done? That's hospital specific. Every hospital needs to have a protocol that can support the definition of brain death. Okay, so I made this little chart just to make it kind of a little bit easier to compare the two. So donation after brain death, donation after cardiac death. So the injury for brain death, oftentimes brain death is caused by severe brain injury. Usually this is trauma. It can be a stroke. That's the fancy way of saying stroke is cerebral vascular accident. Anoxic episode, so somebody drowned and didn't get oxygen. All those things can result in brain death. Donation after cardiac death, you still have all those categories met. Those are still the same causes of death. When we want the organs, the body has to be intact. But the brain, we're not using anything from here. So meeting the criteria for brain death. So if somebody donates after brain death, it's because they met the criteria that defines brain death. If you do not meet the criteria that defines brain death, then we look at cardiac death. So what might that look like? So somebody's in the hospital. I'm sorry I'm picking on Ben. They're a good trauma hospital. They're pretty far away. There's a lot of skiing that happens in that area. So there's a patient who is not responding. They've met all these criteria in terms of not having any neurological reflexes, but they don't meet the criteria of brain death. The family says, I'd like to disconnect the life support. We're going to let him go. What winds up happening is the patient then goes to the OR in Bend, and they disconnect all the life support in the OR, and then the team waits to see what happens. So from a transplant perspective, let's say they take off the breathing machine and the patient quickly decompensates without that support and is no longer able to breathe for themselves. The heart stops. They get a flat line. They sit and look at that flat line for 5 minutes. You've got to make sure that they don't spontaneously convert and have a heartbeat again. After that 5 minutes is up, then the Bend doctor is going to say, this patient, pronounce them dead, and then they're going to leave the room, and then the transplant team is going to come in and start their procurement of organs. So when it comes to procurement of organs, there's an order for that too. So thoracic organs, the heart, the lungs, that needs to be procured first because those organs are more sensitive to time. And then they move down. So then you got the liver and the intestines and finally the kidneys. So that also means there's a lot of coordinations with, again, with the allocation. Who's going to get this heart? Before we disconnect, who's going to get the heart? How are we going to get them there? Is this heart going to fit into this person? And then, you get the person there, and perhaps the person comes into the hospital and they have a fever. Well, now's not a good time for them to have surgery. So now we've got to find a second person that can accept that heart. And then we do the same thing with the lungs, the livers, the kidney. So there's a lot of organization that needs to go into that. For patients who are brain dead, we're able to get more organs because they continue to be perfused through the whole process. So we're able to get the heart, the lung, liver, pancreas, kidney, and intestine. For somebody who is a donor after cardiac death, we can't use the heart. We already know it stopped for 5 minutes, and we don't know what kind of stress it had beforehand. But we can get the lungs, the liver, the pancreas, and the kidney, assuming that the patient actually does pass in an appropriate amount of time. All right, because if they're going to go on for 4 hours, we don't know what the conditions of those organs are. They haven't been well perfused. They could have started the organ death process. Key points: donation after brain death. The time of brain death is the legal time of death. So they're in the ICU, they've been pronounced brain dead, surgery's not for 2 days, because that's how long it takes us to place the heart, the lung, whatever. We're waiting for grandpa to come to say goodbye. Whatever the scenario is, takes 2 days. Death has happened when brain death was determined. Brain death is not the same as a coma. In a coma, somebody can be revived, potentially. That's not the case. This is irreversible brain cell death. On the donation after cardiac death side, DCD is discussed with the family after the decision to withdraw support is made. So it's not like people are going to go up and say, kind of circling the toilet over here. So it's going to be after the family has come to the decision that this is not how our loved one would want to live. We want to disconnect. And then they're approached by somebody who's trained to have these conversations that comes up to them and then says, you have an opportunity right now if you'd like to pursue donation. And then if the patient doesn't expire in that 2-hour time frame, donation isn't going to be an option. Organ donation isn't going to be an option. I should specify that, right? So there's still skin and eyes and other non-organ body parts that can still be donated. So I'm going to pass this off to Ribby, and when Once Rivi is done, we'll have the rabbi talk, and then we'll take some questions.
Hi. So I'm Jennifer Antick, also known as Rivi around these parts, and I am a clinical health psychologist. I have a couple of ways in which I interact with the donation world, and one of them is as a scholar. I'm very, very interested in the gap that Ingrid so skillfully identified. There's a big difference between those who support donation and those who actually register to donate as deceased donors. And it's a big difference between those who support donation and those that decide to donate as live donors. And that gap is not really clear. We really don't understand why intention does not convert into action for people that truly do have the positive intention in the first place. So I'm going to set myself a timer and try to stay within it so we hold time for questions. So what I'm going to do is shift gears a little bit, building off of what Ingrid has been talking about, and talk about how do we promote legal and ethical donation, given this context of the challenges that have been put forth. And so we're trying to both curb transplant tourism, which she's already mentioned, black market donation, which does still occur, both in this country and externally, the purchasing of organs, which is the flip side of that, right? Those who seek and those who seek to sell their organs. And then the issues of coercion when we have family members or friends that may feel obligated. So we are in I didn't mention the other side. So the other side of it is that I participate in donor evaluations for potential living donors. And then I also work with both transplant patients, post-transplant, and sometimes donors after donation if they're having difficulties adapting to, say, life after dialysis, or in this case for donors, just if they're transitioning and wanting assistance in an adaptation. So is my sound okay? All right. Me and Mike, we don't get along. So the flip side of this is the issue of coercion. When we're interviewing someone who says, I would like to donate, one of the things we have to assure through a donor evaluation is that they are not feeling coerced and that they are in no way feeling pressured, because there is no risk-benefit balance for a donor. There is risk. And we want to make sure that our donors are healthy and safe and have no undue harm as a result of donation. So we're very particular about making sure that we consider their needs as part of the process, and that's part of keeping a living donor program vital, literally. We also want to incentivize donation at the same time that we're saying we don't want donation to be coerced, and we don't want donations through transplant tourism and through illegal or unethical means. We don't want people who would be more vulnerable in our communities or in communities in other countries where they are so economically disadvantaged that they might feel the need to act as a vendor with their organs in order to get money. And so at the same time, we also are still trying to promote. So it is really a delicate balance. We've already talked about opt-in and opt-out, and we're going to talk some more about that about different countries. So what I wanted to do is, and I wish it's a little bit bigger, and I apologize for that. I'm going to point out a few things. You can see at the top, this is Spain. Spain has the highest person per million donation, which is the standard way of evaluating the rate of donation across countries. Spain is doing some very interesting things we're going to talk about briefly, and I'm going to point out the U.S. is third. Now this is the 2017 numbers. I wasn't able to obtain the 2018 numbers. I don't know if they've yet been published. You haven't seen either. So you're also going to point out down here, we have a number of countries that we consider to be well-developed and some that may have fewer current institutional resources to support donation. We'll come back to this one. So in Spain, what's different in Spain? Well, there are a couple of ideas that are oft-touted, and those are mostly that they have had an opt-out policy, meaning people are presumed to become deceased donors unless they opt out during life, since 1979, and the one that comes closest after them is Croatia, which was actually not on any list I could find other than some published studies, but they're at the 38.6 people per million as of 2016. we're going to come back to Spain because Singapore also has an opt-out system. And yet, and they've had it actually for quite a while, since 1987, they amended it in 2009 to have a top end of 21 to 60, but all individuals 21 to 60 are assumed to be potential donors. They also outlawed organ commercialism, and they have heavy penalties, jail time. They've actually made sure to address religious and cultural concerns. They obtained from several key imams fatwas that acknowledge that there are no religious barriers in Islam to donation, which is a key issue in Singapore, a very, very large Muslim population. And yet, they still only get 7 to 9 per million population per year of deceased donation. So it's not likely that it's just opt-out. I could give you lots of examples, but for the purposes of time, I thought contrasting these would be helpful. So coming back to here, we just said 7 to 9, and we come down here, and that's down, where's my flashy thing? There we go. 7 to 9 is somewhere between Turkey and Germany, and yet Spain, with very similar laws, is up here. So what else? Let's look at the UK. The UK in 2018, although you know they're super busy freaking out about Brexit or no Brexit or whatever, in the meantime, they did pass a law last August for an opt-out system. And that's a big change for them. But they still have had a fairly decent showing. So again, coming back here, we see the UK is at 22.5 relative to other countries. Max's law was named for a boy named Max, who was the recipient of a deceased donor heart and is living and healthy now as a result. And they passed this law. It will come into full effect in 2 years, well, now a year and a half. 82% of people in the UK say they favor donation, but only 37% have registered with the NHS Organ Donor Registry. Less than half of families asked after death, for those who had not yet opted in, because it was an opt-in system, agreed to have the organs donated. So it's not just about the laws, right? There has to be something else happening here. And this is me as a psychologist saying, that's really interesting. This is fascinating to me. How can we promote, again, healthy, ethical, and legal donation? I'm super interested in Israel. Many of us are. Israel has made massive strides in recent years, and I was fortunate enough to interact with the nephrologists at Hadassah Hospital last year when I was doing a Brandeis Israel Studies Fellowship. And this is one of my areas of scholarly work, so I'm very interested in what they're doing differently. And they have made, as I mentioned, massive strides recently. But until 2008, organ trafficking, as we understand it, or organ commercialism, was still legal. And there were 150 to 210 Israelis leaving every year to go either to receive an organ externally. And they were going to some of the places that Ingrid mentioned. India, Turkey at one point was very popular. We can go through a long list. Now, also what was happening was Israelis were leaving to donate because they could be paid. So Israelis were leaving to donate, Israelis were leaving to receive. And what they did in 2008 was they passed a law that said you can't do any of that anymore. It is illegal to leave the country to donate, and it is illegal to leave the country to receive an organ. So this is what has happened very recently. And in that time, I'm going to step back and say they were trying to do with this law, do 3 different things. There is a big issue that remains, which is that brain death as a medical criterion is not a uniformly accepted criteria in Israel for death. That's an issue. It's not just an issue with the ultra-Orthodox, but it is an issue with the ultra-Orthodox specifically. And then many Israeli doctors were unwilling to go through the training to ascertain brain death. They just have not had uniform cultural acceptance of this concept, which is going to be a barrier. Organ trafficking, as I mentioned, has now been nearly shut down completely. They've been very successful. And they also did something interesting that a lot of states in this country are been working on, but it is a states' rights issue, not a federal issue, which is reducing disincentives, please pardon my double negative, reducing disincentives for potential donors. You see, if I were to allocate a particular organ to a particular person, that person's insurance would cover my surgery. But there might be indirect, there usually are, indirect costs that could accumulate over time. And so one of the questions is how do we, in general, and Israel and the US, make sure we are not paying for organs and making sure we have some ways of incentivizing people so that they are not, again, disadvantaged as a result of donation. Does everybody follow that? Right? We don't want anybody to be worse off as a result of donation, period. Okay. The last thing was that we, of course, just like everywhere else we're talking about, there are not enough organs that are needed. Overall live donation in Israel has doubled since they passed the law in 2008. It's been estimated in the Orthodox communities, for which we do not have as precise data, that it has tripled. 300% increase in live donation within the Orthodox communities of Israel. They also added something very controversial to the law, and it was actually a priority structure for future need, meaning if I donate a kidney and at some point in time in the future I need a liver transplant, I would have when measured against another person with equal medical need, I would have a slight advantage in receiving an organ. Quite controversial, and there are levels of priority that we don't need to get into because we don't live there. At least I don't think any of us live there at the moment. So it's still being tested in the courts, and there's no evidence that that has made a big difference, but it is an interesting construct. All right, so what are we doing in the US? Ingrid has already introduced UNOS and the NOTA systems and laws. I just wanted to mention that part of what UNOS does is they do observe, they do monitor, they maintain databases, and they also support families and donors and recipients. Families, donors, and recipients. Okay. As I mentioned, there's this question about, it's illegal to sell or buy organs. We generally agree on that. And how do we make sure we don't have these disincentives? So what about tax credits? So a bunch of states, which is super exciting, right? No one really likes taxes. It's right about that time. If you haven't done your taxes, you will soon. Tax credits are not exciting, but there was a question of tax credits being an option. Can we make sure it's not a cost for cost payment, but can we offset some of the cost for a person who's willing and interested in donation? And so 19 states have actually enacted tax deductions or credits to living donors. Oregon is not one of them, but they do, there are both direct and indirect costs that can be reimbursed. There are donor leave laws. That's one way we can make life easier for a donor, a live donor, obviously, is that if you're a state employee, there are donor leave laws in most states. And for private sector, there are they may be paid or unpaid, but they are required to try to cooperate with a person that wants to donate an organ. We can tell you that donation rates do not appear to be statistically anyway related to these particular initiatives, but people keep trying. I mean, some of them are as much as a $10,000 tax credit. Some of them are substantial, $5,000 to $10,000. That can make a difference for most people. Okay, so where does this leave us? Donors are still lagging, and there's a real question, what is it that makes Spain so successful? Well, I'm quoting a health policy author in Israel who said, organ donation is embedded within the Spanish culture. What is different in Spain? It is that they are community focused. What is different in the Orthodox community as well right now is that they are donating to their community. And honestly, most of them are non-directed, non-related living donors. They are altruistic donation as we define it. They are not directed toward a particular individual, right? I hear someone needs, or I decide I want to donate. So this is one of the questions. Now, I will tell you that I also learned that the Christian community, so more by religion than by other structures, but the Christian, Muslim, and Jewish communities in Israel are donating within community more than donating in general. And so I just want to have us think about that a little bit before we go farther, of what that might mean to you, what you think about that. I wanted to give you some particular psychosocial variables that I think are interesting. And I read about a qualitative study that I think is fascinating about recipients' preferences for a living donor or a deceased donor organ. And this assumes that the recipient is in a position to make a decision, that they are well enough to decide. And what they did was they asked them questions about their preferences. And most of the people said, yes, of course, I would be willing to accept a non-directed donor, but some did not. Some said, no, I would rather not. And so I wanted to go over those answers of why that's happening for a few people. So some of the main themes for those who were willing to accept was that they would prioritize their known family, friends, social structure over people that they didn't know. That they would rather, their family members or friends, not be even at the most minor risk than have a stranger donate. Some people felt, I'm as deserving as any other recipient. I would accept any organ available to me. And some people said they really were hoping for a live donor transplant for the reasons Ingrid mentioned, that the potential for a longer lasting relationship with that organ is real. For those who were unwilling to accept, though, a non-directed donor, I think this is, again, very interesting, is they said, other people are more important than me, right? Someone else should have this organ before me. They basically thought if there's an extra person willing to just donate in a non-directed way, that should probably go to someone else. So there's a certain amount of survivor guilt with individuals who are in need of organs, and they know they're in dialysis. For example, if you think about kidney donation, they're in dialysis with people every week, usually 3 times a week if they're not doing at-home dialysis. And it's hard to watch someone else go. And some people really respond to that guilt by shifting that. And what's also interesting is this fear of acquiring an unknown donor's characteristics. We've made movies about this. Yeah, lots of movies have dealt with this. And it is more than a superstition. There are a lot of folks who really believe that they would take the characteristics of the organ donor, it would somehow affect who they are. And that fear actually causes some people to say, no, I would worry too much about that. There's also concern for the donor, just concern about a living donor, that saying there's just unnecessary risk, even though we think that our processes for life donation are fantastic. And the systems of both technology and individual support for live donors are really robust. So let's see what else. A little bit more. So this is the cultural barrier question that I just want to pose to you. You don't have to answer it now, but I'm hoping we'll have time for questions and answers. But who is an acceptable donor for you? Who would be an acceptable recipient for you? Does that shift if it's someone from your culture or community? Is it different if it's family or not family? Is it different if it's friends of family? Someone unrelated or someone totally anonymous? What do you think about the donation process? The communities with higher risks for kidney disease, African Americans in our communities are at much higher risk for, again, some of the reasons Ingrid mentioned, much higher need for kidneys and a fairly low donation rate that comes from for a variety of reasons, including having, as broader communities, lots of negative interactions with our healthcare systems and not being treated equitably. That's an issue, right? So if we only give to our own, whatever our own is, however you define that, what does that mean for the broader communities that we live in? In some families, accepting an organ, by the way, from a parent or a child is absolutely anathema. In some Mexican American communities, I say communities because subcultures, a parent will not accept an organ from a child just with the concern that they might be even potentially minuscule fraction of a possibility that they would foreshorten that child's life. That is not guilt that the parent could live with. There are children that would never want to accept from a parent for similar reasons, right? There are, they may feel selfish, they might feel unacceptable, there may be an unacceptable amount of risk. There are issues with what we call higher risk organs, say from someone who passes away from opiates, who might have organs that are perfused. They're healthy in other ways. But as a result of the drug exposure, they may have unknown disease that is not yet detectable at the time of procurement and donation. And there are a lot of people who will not be willing to accept a donor organ from a person who died from an overdose. Whereas the deceased donor or donor that is unknown may actually have not as much potential to keep them alive and healthy longer. So what if I'm concerned about donation to a family member? I have worked, I say it's very, Portland's a small place, right? So I have worked with individuals who, until they were asked many, many, many times in various different modalities, were finally admitting that they felt like they needed to donate. They felt pressure to donate, which is, we don't want that. We don't want that to happen. Then we had to talk about what are the options. Well, I can tell you, for anyone who might consider it, that all the way until they say count back from 10, a person can change their mind. We want living donors that are healthy and happy with their choice. It's critical. Having said that, very few people do. Once they go through the process and they are able and identified as effective donors, they are consistently pleased. And you can look on YouTube and look at donor and recipient videos and look them up and see the patient experience, the recipient experience, the donor evaluation experience. There's a lot of really interesting stuff out there. And we have Donate Life with us today for exactly this reason, for you to get some information while you're here. Are there other interpersonal barriers or institutional barriers? These are the things that we want to think about as systems and as individuals. What is it would make a difference for you? What would flip this switch from intention to action if you were either comfortable with live donation for a kidney or deceased donation for any of the other options, including kidneys, for your driver's license to make that shift? We do know that personal connections matter, and personally knowing a live donor that is successful and happy and comfortable and made it just fine makes it more likely that the people around them will consider donation. We know that direct and even slightly indirect, which I seem to see more of personally, knowing about a potential recipient in some personal thread makes it more likely that individuals will consider donation. And these are the shifts that we want to make. So I'm going to quickly, I've got 3 minutes. So I'm going to want to mention 2 websites. We're going to click on Renewal just to have you see it. So this is an in-community organization. Renewal is on the East Coast. It's in Brooklyn, and they connect donors and recipients within the Jewish community. And then the Halakhic Organ Donor Society is mostly active in Israel. But I put the website here if you're interested. It's nice and short, not easy to forget. And they have a little quiz about halakhic law, halakha and myths about donation. And it's actually a very nice organization, and there are others. Right before I do that, this one little tidbit story I want to share with you. When I talked with a nephrologist at Hadassah, where they have centralized all of their donations, one of the things she told me that made the biggest difference from her perspective, and we have no data on this, so I'm sharing with you a story. And the story is that there were 2 Orthodox men in their mid-20s, both of whom were on dialysis and in need of transplant. And one of them received an organ in time, and one of them passed away from severe kidney disease and did not make it, did not get an organ in time, did not get a match. The one who lived has completely shifted his life, and he spends his time going from community to community, shoal to shoal, all over Israel and a lot of parts of the United States, talking about his experience as a recipient and the need for donors. And from her perspective as the nephrologist in the transplant team at Hadassah, she said from her perspective, those kinds of work and that particular work is a very large part of what made the shift from a lower number to a much higher number of people per million transplant. So that personal story, the personal connection, getting to know people makes a big difference. So we're going to
to take this opportunity to thank Rabboni Shalom for bringing me to this moment, and also to Renewal, and especially to the donor who has given me the opportunity for a second chance at life. There's no words that could possibly express the gratefulness and the sincere appreciation for this Mesiras Nefesh that this person has undergone. And I just want to say thank you to everyone who has supported me over the last year and through this period while I was on dialysis. And I hope, as Hashem, to be involved in Renewal's.
Nationwide, there are about 90,000 people waiting for kidney transplants, and there'll only be about between 16 and 17,000 kidneys available each year. And again, people don't get transplanted, they're going to die.
It is amazing to me how many people are out there are willing to make this sacrifice, because it's one of the few instances where you're actually giving life.
Dialysis was a true nightmare. I can't say it enough. It was an absolute nightmare. First of all, I don't know if people realize that when you're on dialysis, you're talking a sterile room. Like no air conditioner, no fan, nobody in the room, masks, gloves, Purell, wash hands.
This entire process began with me, with Renewal. You know, it wasn't that I had decided on my own that I was interested in donating a kidney, and then I contacted Renewal for advice and assistance. Really, Renewal approached us, and they were interested in running a program in the shul, and that's what triggered, you know, the journey which ultimately led to my kidney donation. So I was really involved and in touch and in communication with the members of Renewal from the very beginning. And
I want to thank Ingrid and Jennifer Rivi for being here and for sharing with us. And I want to say that this is a topic that has some real closeness to me. My father was on dialysis for 5 years. He did not get a kidney. He died of end-stage renal disease. And we're grateful that he got 5 years, because at his age, the expectancy was about 2.5. So we feel like we got extra time. But, you know, my dad is the reason he saved countless millions of lives, because he was the first team that connected cigarettes and cancer. And there's a part of me that would have liked to have known that someone would have returned that favor, that the universe would have been able to. And it was not to be. So I want to share with you some thoughts on the transplantation in Jewish law. And it's not an area I don't claim to deep expertise in there, but I have sufficient expertise, I hope, to share a little bit of life. And there are 3 general areas that Jewish law has to look at. We've been talking about the different body parts, but there are 3 main areas. There's an autograft, which is a transplant from yourself to yourself. There's an allograft, which is primarily what we've been talking about, where you're getting a transplant from another human being. And finally, there's a xenograft, which is from another animal. And each of those is going to have a different set of halachic ramifications as to how we go about dealing with that. And with the live donors we've heard about, it could be blood and blood products, or bone marrow, kidney, partial liver, partial lung, and we've looked at cadaveric transplants from cadavers and this sort of thing. And that certainly is an area where there are some halakhic types of issues. So first of all, from a Jewish law perspective, up till now, receiving any sort of organ from another animal is completely acceptable in halakha. And I know many Jews, when it comes to things like pigs, they think, well, wait a second, am I allowed to get even? I've been asked by congregants about a valve made from a pig heart valve. And it's interesting, right, that in Judaism we're allowed to get benefit from a pig. We're not allowed to get dinner from a pig. So those are a little bit different. And I don't know how the pig feels about that, but that's a different question certainly as well. And therefore those are okay, and certainly heart valves are a pretty common example of that. And so there are issues, however, when we're dealing with an allograft from another person, whether a living or a deceased, right? Living or deceased, that is a problem. So from yourself, not a problem. From another animal, not a problem. But from other people. And those issues, I think, are sort of important ethical sorts of things, because they deal with social issues, they deal with issues surrounding the recipient, issues surrounding the donor, that each of those have a slightly different sorts of concerns. And as you know, we are definitely very concerned always with the ethical dimensions of our lives. So we have here a number of terms which seem to sort of allow it. So I'll sort of run through that a little bit, right? I think many of us are familiar with this, the Jewish notion of pikuach nefesh, that pikuach nefesh dochet haShabbat, that for the sake of saving a life, you can even override the central sanctity of the Sabbath, and that you're allowed to break Shabbat except for adultery, idolatry, and murder. Right? Those are the three ones where it's not, which is a reminder, by the way, that life is of very high value, but life is not the only value in Judaism. What sort of life matters to us as much? And there are sort of cardinal sins which abrogating them would be worse than saving a life in those cases. Judaism, and we are lucky for a tradition that emphasizes healing, right? It's the Torah says, rapo yirapeh, a strange verbal form which means heal, you shall certainly heal. And out of that, the rabbis, by that double word, means that you need to actively heal. And that's not immediately justifiable for people who believe in God, right? If God is the one who runs the world, by some people's theology, then for me to accept medical help is to say I am going against God's will. And we certainly find on the cultural dilemma, cultural lens, I'm sure you each deal with people from different religious backgrounds. For example, Seventh-day Adventists, I think, are the ones who come most to my mind for whom that is not permitted at all. But the way we interpret the Bible, that's not been a problem. It's one of the reasons we have so many Jewish doctors, quite literally. That's a joke. I mean, it's not. We like to joke about how many Jewish doctors it is, but it really comes from that commitment to the value of life. The fourth bullet point down there, zeh neheneh v'zeh lo chaser. One party is helped and the other is not harmed. I'm going to return to that in a second. So, when it comes to a live donor, our bodies ultimately do not belong to us. That's a fundamental notion of Judaism, and it's an example, by the way, I think, where Judaism and being an American, contradict. Because in America, it's my body and I get to do what I want, and that's sort of a very deeply sort of held notion. But in Judaism, our bodies belong to God; they're on loan to us. We sort of, we get ensouled, we get our souls placed in these bodies, and we have an obligation, right? We have to live healthy lives, we can't put ourselves at risk or in danger. That's actually forbidden, right? So, my mom probably thought that I should have followed that when I went skydiving, but I thought it was relatively safe, and here I am. So I guess I'm right, and my mom was apoplectic. Mom, can you hear me? So what are the requirements, therefore, if I want to donate an organ? One is that my surgery to have that organ removed has to be not dangerous, right? It can't be a danger. Now, there's a time element in this, right? We started, 1983 when we had cyclosporine and we could begin to prevent rejections. People who were involved in this in the early days couldn't have met this obligation. There was a far, far higher level of risk, and certainly whenever we're pushing the limits of our current medical technology, that action is endangering our life without a return on investment. If all the world were Jewish, that would present a problem for research, by the way, but it is certainly how we sort of, the other ways we donate to the world, but that's an interesting sort of thing. There has to be an assumption that the donor's life can continue normally after I've given my organ. I need to be able, right, because I have to protect my life. I've got to be able to live like a good life after that. And that good life means I shouldn't have, or I should have a very low risk of having any sort of chronic issues, right? If I give a kidney and now I'm going to have chronic issues the rest of my life, and that was foreseeable, I actually would not be permitted to give that by some perspectives, or at least certainly not required. We'll get to that in a second. And finally, right, we don't do things, we're very tachlis, we're very practical people, right? So there has to be a really good success rate in the recipient, right? So someone who doesn't have a good chance to live, and I'm giving my organ to them, and when we talk about Jewish law, it's important to realize, right, these laws here will probably outlast America, and therefore they are going to exist in different cultures and contexts, as they already do. Right? We learned about Israel and some of the problems with that, but there are Jews in Mexico City, there are Jews in wherever it may be, and the cultural assumptions around organ donation are going to be different in those places, but a observant Jew would still consider themselves to be obligated, at least to be within this Jewish conversation around that. So when we get to sort of live donation, the sort of organ in question also is going to come into place and be involved, right? So with kidney donation, right, it's very interesting. There's the literature is split on this, and this is, again, as I told you, this is something that would have helped my dads. There are some rabbis who will prohibit donating a kidney, and others will allow it, but under the rubric of midat lifnei mishurat hadin, or midat chasidim, meaning that this is a pious action. It goes above and beyond what can be expected of us, but pious, righteous people might choose to take this additional step and so do it. And it's Judaism, so we're not surprised there are multiple opinions. Even with kidney donation, there's a very strong thread of the tradition which says you're required to give because of the commandment, you shall not stand idly by the blood of your fellow person, right? So when Rivi was talking earlier about Israel and different religious communities and having people go in, that is those in just like in a court of law, what the judge had for breakfast can actually determine how they rule in the case. We know this for a fact. So too, having these stories is going to prime certain communities for how they are approaching the law or interpreting the law, and that's one of the big changes that we've actually seen. So what are some of the other limitations for these sorts of donations? You have to be legally competent. So what is that in Judaism? I'm looking at a couple of folks from my class. Will, Sammy, how old do you need to be legally competent? I'm asking you Judaism. 13. That's right. You need to be a Jewish adult. So an 11-year-old who has a sick relative can and might be able to donate to them would not be allowed to give, and their guardians, their parents, can't require or make them give because parents don't own their children's bodies, right? We don't own our own bodies, all the more so our parents certainly can't do that. Another category, people who are not mentally competent. So people who have cognitive impairments are unable to give consent, and their guardians cannot give consent for them. And there's something rather beautiful about that in regard to the fact that it is protecting a class of people who can be taken advantage of many times in society, right? I mean, you can think about in this country, there wasn't that many decades ago where we had forced sterilization of people who were on the lower edge of the intellectual scale. So Judaism sort of outlawed that right from the beginning, and it's interesting, that's just a general Jewish notion of who is obligated and who's not, and what do you need to have to be able to make a decision. So that's like a pretty intense kidney, but for other sorts of things with blood and bone marrow, the general notions is that at the very least it is permissible to donate because there's little danger to the donor, and because there's little danger, there's a notion that relatives most certainly should donate, and if they refuse, there are even therefore cases where certain rabbis will feel that the person can be coerced to give blood or bone marrow, right? So before we're dealing with the kidney, we're dealing with a much more intense, you only get 2 of them, right? The bone marrow is going to regenerate, the blood is going to regenerate. The risk to there's pain, some discomfort in bone marrow, but the risk to you is relatively very low, and therefore the halakhic obligation on us changes, and there's a higher bar that is set for that. We got a chance to learn that in the U.S. and in many advanced or developed countries, there was a real attempt to limit the sale of organs and that sort of thing. And here it's pretty interesting because the halakhic literature, once again, has varied, and there does not necessarily seem to be a prohibition of donating an organ in exchange for financial compensation, but very important people such as Rav Moshe Tendler, who you'll find on the Hode's website, mentions that it's definitely quite disturbing from a moral perspective. And that's often a difference in Judaism, right, between what is permitted but should be discouraged. We can have both of those things at the same time. So that gives us a little bit of a sense from the Jewish perspective on living donors. What about cadaver donors? And let's go to the next slide. Okay. So it is a basic tenet of Judaism that the way we treat the dead is a reflection of how we will come to treat the living. The way we treat the dead is a reflection of how we will come to treat the living. And anyone who doubts that needs to just turn their eyes to the Shoah and to think about how the Germans treated the dead bodies of Jews, which they harvested for the skin for lampshades, the teeth for all sorts of things. And so the Torah itself really speaks, quite definitely that the final one, Isur Hana'ah, we're not supposed to benefit from the dead, and that we're not, as I'm sure many of us know, that when somebody dies, we really emphasize a quick burial, and will there be a postponement of the burial in order to harvest the organ, let alone nivul hamet. We don't desecrate the dead. The Torah actually gives the example of some people who had been subjected to the death penalty, meaning sort of the worst of society. And even in that case, we're told the bodies could not be left in the trees overnight because that would be a desecration of the human and the divine image. The people had to be taken down quickly after that. So those are on their own, there's a certain purity to them, which is about the dignity of the human being and of how if we preserve a respect even for the dead, that will bleed off and ideally have us be better with the living. So we have to hold on to that when we see now how the halakha is going to wrestle with one set of concerns which are very noble and moral and ethical, except that now we have a different notion. So what we normally do in Judaism in that case is we look for the loophole. And a lot of people have problems with loopholes, but I want you know, loopholes are the reason that we are not a fundamentalist religion, even in the ultra-Orthodox segments. It is our ability to generate ways through the Torah and to hear God's will that keeps fundamentalism at bay. So if the loophole bothers you, please hold on to that piece of it. It's a really, really important sort of thing. So one of the things I really love, right? I mean, the other thing that's not on here is you're not allowed to steal from the dead, right? Grave robbery, no, big no. So the rabbis argue that since the organ is going to function in the body in which it is placed, it's not stealing from the dead, it's not desecrating the dead, and it's not worried about burying the dead quickly because the organ is alive. And it is still moving on, and therefore it shifts it from this category of being the organ concerns for the dead into the living, and we already learned about when those would be sort of okay. So it's an interesting, I find that sort of amusing. So most poskim, most of our decisors do permit cadaver donations. But there are limitations. And again, if you know about autopsy, in Judaism, we really frown on autopsy. And the exceptions are if the law requires it, right? If somebody died at the age of 24 and the police are involved and they're worried about what may be in there, then we acquiesce. I don't know that we'd have a choice not to. But the law of the land is the law of the land. So is it law? So we follow it. And also, if there's a real clear medical advantage that's near in time, we also can allow autopsies. But we don't allow an autopsy to train new medical students, for example, because that's very distant from the current thing. So cadaver donations are okay if the needy recipient is at hand, right? That time frame I was talking about. If the recipient's life is in danger, if they're just starting dialysis, it's not necessarily in danger. They could have 70% kidney function, or I don't know how much, when you go on to dialysis, I don't remember that particular, Less than 20, okay. So the donor should have consented while alive to have their organs donated. And then the final piece is, I've been talking about just sort of the whole stream of Jewish halakhic tradition, but I want to bring it back down because we're standing in Neve Shalom to the conservative movement. And in the conservative movement, we are required to donate our organs as post-mortem, right? We are actually absolutely required, and I'm going to read you that statement in a second, but here's my little driver's license, and on the back it says, upon my death, I want to be an anatomical donor. So if we've got the opportunity to sign up in the rear, and if you have not yet done that, you're obligated. The rabbi told you. So I want to read you this lovely statement from the year 2000. It was one of the Rabbinical Assembly resolutions based on earlier Tshuvot as well. So, whereas the Rabbinical Assembly passed a resolution on educating conservative Jews regarding organ donations at its May 1996 convention, and whereas every day as many as 200 people in the U.S. join the list of those awaiting organ transplants, with a death occurring every 3 hours as a result of a severe organ shortage. Again, this is from 19 years ago. And whereas Jews do not constitute a proportional share of organ donors, which Rivi alluded to, we give twice the tzedakah, twice the charity of the average citizen in study after study over the years. but not when it comes to organ donation, right? Possibly due to the misapprehension that Judaism prohibits organ transplants. And whereas the Committee on Jewish Law and Standards has concluded that organ donation is not only permissible, but a mitzvah, meaning you're obligated for it, therefore be it resolved that the Rabbinical Assembly reaffirms its 1996 resolution calling for each conservative synagogue to encourage organ donations among its members through an educational program, check, and campaign, the goal of which is to have an increasing number of people sign organ donor cards and to inform family members of their desire to be organ donors. So we could probably do a little bit more than a snowy night came here for, but what I love about the Jewish approach to these questions is that there is a sophistication, a moral and an ethical sensitivity, a real veneration of life, but other values also come into play. And it is in the careful consideration and balancing of those different concerns, I think, that we avoid making mistakes, and that we do the sort of ethical and moral analysis that is part of the medical field, and that we try to live good and godly lives. So again, if you are not signed up as an organ donor, this is your night to get to do so. Thank you. And I guess we can hold it open for some Q&A from maybe just a moment or two, if there are. Yeah. Okay, we got time for maybe one more question, if there is.
So organs are much different from ion tissue. So as Ingrid lovely explains every detail of how that works, right? Organs do not last forever, right? So if you are a little bit older, your organs probably will not be viable. But we like to always say, don't make almost have no age limit. Actually, as you age, your skin becomes much more viable, and your corneas. Even if you wear glasses, corneas are something that you can donate. Even if you die of cancer, corneas can still be donated. And so organs, in particular, there is an age limit. Usually it's around 80, sometimes a little bit younger. It depends on, how you have died, obviously, and the causes that's, having an effect on the organs. There's a lot of factors that go into it. Age is a factor, but how healthy are you? Because there's 30-year-old organs you don't want. Yeah, definitely. Take the 70-year-old organ. Yeah. Yeah, there are many factors that come into it.
And on my 50th birthday, I'm going to have a brain transplant. Yes. Thank you.